Good morning. This is Doug Sawyer in Nashville talking to you. I'm going to present a couple of cases, but mostly to generate some discussion over some ideas that I think are not quite in the literature, and then an idea for a study that I'm looking for feedback on. So I hope this is very interactive, and I'm happy to not get through all these slides. I get about 30 slides to go. So the cases are familiar to most of y'all, so I'm not going to spend a lot of time talking about the cases as much as the ideas they might bring up. So the first patient I'm going to mention is actually someone I saw back in Boston, where Jeannie and I overlapped at Boston University. And this is a woman who came to heart failure clinic 3 years out from treatment for breast cancer. So my slides are not advancing. Here we go. So she had been treated with standard dose chemotherapy, adriamycin at 240 milligrams per meter squared, and 3 years later began to get short of breath and was sent for an echocardiogram, which, oops, let me back up, which showed that she had developed systolic heart failure with an end-diastolic dimension that had gotten bigger and an EF that had declined from a pre-treatment echo that was normal. And her oncologist was happy that she'd cured her cancer, but obviously wanted help here. And it was, you know, she's not the usual high-dose adriamycin cardiomyopathy patient. And if you look at the paper that we all like to cite from Swain on the cumulative exposure relationship to cardiac events, she's at that red arrow where there's what most oncologists would say less than 10% risk of a cardiac event, and what some programs even say is below the threshold for causing cardiac toxicity. So coming to the heart failure staging system on this next slide, she basically, when she started her chemotherapy, she was, we'd all agree, a stage A patient, regardless of what else she had in her history. And when she finished chemotherapy, this is probably an area of debate. I tend to think of anybody who's had anthracyclines as a stage B patient. They've had some damage to their heart, and we can talk about that. And please chime in if you disagree. I want this to be a conversation. And here she is now. She's a stage C patient with symptomatic systolic heart failure. So coming back to her, she was treated as a stage C patient, given ACE inhibitor and beta blocker. She actually had a low blood pressure at presentation, so this took a while to get her up to her maximum tolerated dose, and she actually got to full dose beta blocker. She had improvements in her symptoms. She was diuresed as well. Eventually came off diuretics, and then her EF improved to 35%, and her end-diastolic dimension shrank a bit to 50. And this is a little bit different than, let's say, the Cardinale group has reported in their findings, that if you wait too long after development of systolic heart failure after anthracycline exposure, you have less chance of recovery. And so you could debate whether this was solely due to her anthracyclines, and perhaps there's something else going on, including the fact that she had a strong history of heart failure in her family. So keying off that family history, a question comes up is, what is the role or relationship of family history of heart failure to risk of developing cardiac toxicity from chemotherapy? And I open that up as a question, as I don't know that I can't find much in the literature to help figure that out. It makes sense that it's a risk factor, but we don't have much to go on in data, in regards to data. So please chime in if you have an answer to that. We started a study about 8 years ago at Vanderbilt to get at that and some other questions. And I want to show some of that data and then come back to her and another patient and an idea. So we call this the PACE study. Carrie Geisberg-Lenneman worked on this, and now she's in Louisville. And she came up with the term PACE for predicting adverse cardiac events, and PACE 2 is under design, and we're calling that preventing adverse cardiac events. And we enrolled about 130 patients in from the enrollment pre-treatment, and these are patients that are scheduled to receive either anthracyclines and or ERB2 targeted therapy. And the primary goal was to understand some of the behavioral factors that would determine toxicity. as well as get at some of the biological predictors that I'll come back to that might relate to those behaviors. And the first part of that was published last year, and really just talks about the transitions from stage A to stage B, and it presented in there are the risk factors for this largely Middle Tennessee population of breast cancer patients, and these are all women. And what's not surprising, I guess, is that there's a lot of cardiac risk factors present, including about a quarter of women have a family history of heart failure of a first degree relative. So how that plays out, we don't have the statistical power to say whether that's a risk factor yet for a cardiac event, though there is a trend towards that group with a family history having a higher likelihood of having a decline in cardiac function. But you can see there's lots of other risk factors that might be helping those families, like obesity, hypertension, dyslipidemia, and tobacco use. That cohort, the first part of it, this is just their change in ejection fraction over the first year of follow-up after receiving anthracyclines, and about 20% of them have a decline in cardiac function that you might call clinically significant. So genetics in heart failure related to anthracyclines has been looked at by a number of groups with much larger patient cohorts, and I can summarize it, at least my worldview of it, in this slide. We know that using cell-based studies as well as animal-based studies, as well as looking at the clinical data, that the risk of toxicity is related to the cardiac myocyte uptake of anthracyclines. So shown on the left are just a couple of pictures of myocytes at the top, A and B, untreated, and at the bottom, C and D, treated with anthracyclines. And the red balls are, so to speak, and D are the anthracycline fluorescence in the nuclei of these cells. And on the bottom right is basically just a simple graph looking at one version of toxicity, in this case the disarray of the myofilaments in these cells, and its relationship to concentration of doxorubicin in the media. And it makes no great surprise that the higher the concentration, the greater the toxicity. And when you look at all the genetic information that's come out, a series of papers, three of which I put at the top, but there's another group in Europe with another related findings, you can cartoon it that the genes that come out as being associated with cardiac events are in the family of transporters that regulate anthracycline uptake and transport out of cells, as well as the enzyme carbonyl reductase, which is in part the enzyme involved in this, the quinone group redox cycling. So the genetic data seems to fit into this basic data that it's how the cell in the heart regulates cardiac cell uptake of anthracyclines that determines relative toxicity or amount of toxicity in the heart. So I don't know if you follow that logic and if I'm making sense. If I'm not, please chime in and ask questions. That's interesting, and if you map it out, just a simple equation on the next slide. Cell toxicity is proportional to the anthracyclines inside the heart cells in time. So if you have more exposure, i.e. more cumulative doses, then you have a higher rate of heart toxicity. And of course, over the years we've learned, others have figured out that if you use liposomal encapsulation, you reduce the anthracycline uptake. If you put dexrazoxane in the mix, you maybe chelate free iron versus the Ed Ye's new hypothesis over inhibiting topoisomerase 2B and might prevent the toxicity that way. But one thing that I want to really bring up is that underappreciated, at least in my experience, is the fact that there are multiple drugs that we use in the clinic that are actually substrates for those same transporters that pump anthracyclines out of heart cells. And examples are diltiazem, verapamil, digoxin. And I guess I'm going to ask a question here. And somebody came off mute, but I want you to come off mute and answer this. How many of you in your practices look at that and make decisions based upon that prior to exposure to anthracyclines?
Doug, we've talked about this once before, but I think I'm not aware of any, data that has looked at anything clinically about the potential drug-drug interactions. But, as a general rule, I avoid those medications in any of these patients for sort of heart failure purposes. But the one caveat being digoxin, I don't have a significant occasion to use that for the treatment of heart failure. I know you do, but so, but I think, but the other ones, I pretty much avoid them anyway. But I think it's an important point, definitely.
I think the calcium channel blockers remain pretty commonly prescribed for hypertension, and I guess it's more important, honestly. I think that the oncologists understand this and the primary care physicians understand this than the cardiologists, because I think we don't necessarily, at least I don't get referred these patients that often prior to their treatment if they don't already have a problem. If I come to the next slide, and please chime in if you have other people want to comment on that.
Hey, Doug, Dan, is that written up in the best practice mode in our new document about consideration for looking at those drugs and avoiding them?
That specifically is not stated. What is stated is, generally we would recommend the use of typical heart failure medications for the prevention of heart failure. So those would be ACE inhibitors, beta blockers. We talk about that, but we don't say, I don't think we specifically call out these drugs.
So this might come up in discussion of atrial fibrillation control, rate control, and treatment.
Mm-hmm.
Definitely.
So do you think we could have something in there, put something in there about that, or do we have anything about atrial fibrillation?
I think I would think we should put something in there. Doug, I don't know if there's at least animal data that sort of goes along with your theory.
Yeah, no, actually it's more than a theory. I'm going to go to the next slide, and if you look, this is just a cartoon of anthracyclines fitting into all the things that can cause cardiac injury and remodeling. And then in green are the things that I think about, and Dan, you just mentioned that we usually prescribe ACE inhibitors and beta blockers to prevent problems and or reverse problems. I tend to say treat blood pressure aggressively, although I know that the ASCO guidelines are not as aggressive as this recommendation for 120/80. And then at the bottom, I put in a reference of a really nice review of this exact issue, which covers a lot of the preclinical literature up until this was published in 2006. And basically, there's a lot of literature showing that cardiac toxicity increases whenever you put in place other drugs that are transported by the same system, which will slow down anthracycline efflux from heart. Now going back, there's an echo someone, but going back, the oncologists actually thought that putting these drugs would increase tumor lysis because you would prevent the MDR, multi-drug resistant transporter, from pumping anthracycline out, so you overcome it. And that's a lot of how this, data that's showing the heart was adversely affected got started. But it was dropped, and I think it is dropped in a way that most clinicians don't think about this. And I think of it, and when we were writing those guidelines, I thought of it strongly enough that you could even put a, level of evidence C recommendation to avoid these drugs. In fact, if in heart transplant patients or kidney transplant patients on cyclosporin getting anthracyclines, I think really have to be thought carefully about for other alternative, immunosuppressants. Any comments on that?
Well, I think the really prominent drug on that list, amiodarone, we certainly use that a lot, especially when people develop atrial arrhythmias. So I I hadn't really considered that there was a place for some sort of increased toxicity. More, I was using that because of its efficacy for AFib.
Sure. You know, I think that the clinical literature may or may not ever develop, but the way it might develop is out of big databases like the one on the West Coast in Kaiser or some other. So if people have access to that, maybe someone can go answer this question. But I don't know if we have to wait for clinical data to recommend, and I'll give you an example. So let's go to the next patient I want to mention. This is a patient that did get referred prior to treatment. 55-year-old nurse educator at Vanderbilt who had early stage breast cancer, ER positive and HER2 positive, with a treatment plan that was outlined by our oncologist to include cyclophosphamide needromycin, similar to the last patient, and then followed by Taxol and trastuzumab. And she had a past medical history of hypertension, hypercholesterolemia, and mitral valve prolapse. And she was referred for pre-treatment consultation, and someone had already for an echocardiogram, which I'll get back to. And so here, you know, what do we recommend for her? She's a stage A heart failure patient now going into this treatment regimen. She's already stage A because of her hypertension and her maybe sedentary behavior at that point. And at this point, you know, treat her blood pressure, treat her dyslipidemia, encourage her to exercise, discourage her from doing things like drinking or any other bad habits. And then our guidelines right now would say give her an ACE or an ARB. I saw her, and her medications at that time included, lo and behold, you know, amlodipine, and a substrate for that transporter, and simvastatin. Her blood pressure was normal in the office, although on her stress test she had gotten up to 200/110 with stress. And then she had a elevated hemoglobin H1C, or borderline, I guess, and then a BNP that was normal. Her electrocardiogram was normal. Her echocardiogram showed mild concentric LVH and a normal size ventricle. So what would you guys do in this case? So I ended up switching her off amlodipine to Coreg and kept her blood pressure normal and tried to do that throughout her treatment, which it stayed normal. Her LVEF was normal. I didn't hit the forward button enough. In terms of other recommendations, one of the questions that I want to get into in the last part of today is thinking about what do you recommend for diet and exercise, and what's the rationale for that. So I changed her medications to Coreg. Her next cardiac evaluation we scheduled for after anthracycline's pre-trastuzumab, and then the question comes up: what do you recommend for exercise and diet? So I ask oncologists what they recommend to this and other patients, and while in general the American Cancer Society recommends what the American Heart Association recommends, oncologists in general, I don't find that they recommend much at all, other than eat what you can and be as active as you can. So the question is, what's the rationale for exercising, and is there any way we might get at this in a way that might improve outcome? We going back to this cohort we've been following at Vanderbilt, this was one of the key questions that we had going into this, and that is there a role for exercise and then ultimately later diet intervention that might improve outcome? And so we began by just trying to understand what people's habits are. And on this, there are two graphs on this. The one on the left basically shows what people do over the course of 4 cycles of anthracyclines and or progressive trastuzumab therapy. And so we did an exercise questionnaire and looked at their total net hours per week using a validated, I think it's a CHAMPS questionnaire. And you can see that basically, as you might expect, people that get anthracycline-based chemotherapy have a progressive decline in their physical activity. Trastuzumab, it looks like it goes down as well, although perhaps less so than anthracyclines, and of course the combination, the trend is there. And what was interesting, and this is again preliminary, and we're trying to combine it with data that Bonnie Key has been collecting up at UPenn to see if we can find a stronger relationship. But people that are less active seem to be at higher risk for decline in cardiac function. Now, of course, there's all kinds of confounders in this that I haven't shown you in this picture, including things like age, obesity, and whatnot that might limit physical activity. But there is an interaction that supports the idea that maybe an exercise intervention might improve it. We've been coming at this question from a biologic side that was driven by something that you all are familiar with, that trastuzumab, when given with anthracyclines, promoted cardiac dysfunction. And what does that have to do with exercise? Well, first of all, what does that have to do with anthracyclines and how does that work? I just show you again, coming back to this picture of myocytes. If you look at what happens to the number of myocytes that have this phenotype of myofilament disarray, on the bottom left you can see that if you treat them with a ligand for ERB receptors, neuregulin, you can suppress that phenotype. And if you treat cells with an antibody to ERB2, which is like trastuzumab, you can augment that phenotype. So this system, neuregulin and ERB system, interacts with anthracyclines in the cells in a way that helps explain maybe the interaction in patients that Dennis Slayman et al. Reported in the New England Journal from the pivotal trials of trastuzumab, and led to the FDA saying don't give those drugs together. So coming back to this cartoon I've been using, we would argue that neuregulin and ERB receptors in the heart are a system that helps prevent anthracycline toxicity, and perhaps also, I won't go into it, helps maintain the heart and helps repair the heart after injury. And when we put trastuzumab in the mix, we're shifting towards cardiac dysfunction because of its interrupting that positive signaling system. So what's also interesting, which isn't in the literature, is that when we looked at just the trastuzumab group in this PACE cohort, this is 15 patients that were, we have more of them now, but this is sort of a preliminary analysis. The LV ejection fraction did decline over the course of treatment in the group as a whole, but their blood pressure also rose, and it interacted with catecholamines in a way that we could come back into at the basic level. We predicted that we might see an increased sympathetic tone with trastuzumab, and in fact norepinephrine levels rose over the course of trastuzumab or during treatment, and neuregulin levels that I'll come back to actually declined. And how does this all interact with exercise? Well, I cartooned for you here, and you don't really have to pay attention to details, but neuregulin in the heart is expressed in endothelial cells, and myocytes have these ERB receptors, and physiologically something regulates this system. And we've been puzzling over this for a long time, and one of the studies we did a while back and have continued to pursue is this idea that actually exercise upregulates neuregulin. And I'll show you one example of that. You can detect neuregulin in people's blood. This is the bottom right, upper left, sorry, is a Western blot, IP Western, actually showing that you can detect this 40 kilodalton protein that reacts with two antibodies to neuregulin, and it's detectable in both plasma and serum. And if you take a group of normal subjects on the bottom right, the levels of neuregulin actually are related to a subject's fitness. And then we measured fitness in this group by VO2 max. So people that are very fit have much higher levels of neuregulin than those that are not. And there's this one outlier that actually was a self-declared bodybuilder that obviously had a higher lean mass. So we think that neuregulin is an indicator of fitness and actually gets perhaps activated by exercise. And over the course of cancer treatment, whether we looked at kids with Steve Lipschultz on the left or women with breast cancer in the PACE cohort, neuregulin actually declines over the course of treatment. So these are measurements of blood neuregulin levels, and from before treatment to after treatment, there's a drop, and that's similar in women with breast cancer. And perhaps that relates to this decline in physical activity that I've mentioned and is obviously known to all y'all. The other interesting thing about neuregulin signaling is that it's a lot like insulin signaling. So insulin resistance, which is a obviously well-recognized and common phenomenon in our clinics that relates to cardiac dysfunction and vascular dysfunction, is really also a state of neuregulin resistance. And this cartoon of signaling just is meant to help you sort of understand that once you get beyond the receptors, neuregulin looks a lot like insulin. It activates similar gene expression profiles and growth regulations, but also glucose uptake. And if you make a cell or animal insulin resistance, we can demonstrate that there's also neuregulin resistance. So keep in mind that this all relates to perhaps an individual's susceptibility to the anthracycline cardiotoxicity and or the trastuzumab, which is also interrupting this receptor. And I'll give you one example of that. And I know that I'm showing you a number of blots in this that is atypical for this conference, so I appreciate your interest in perhaps looking at some challenging data. But here's a picture of what happens. If you make a heart cell, if you give it saturated fatty acids palmitate, which is a way to make any cell or animal or person, for that matter, insulin resistant, so that's why we all recommend no or less saturated fat in your diet, you actually interrupt neuregulin signaling. You prevent neuregulin from turning on this cytoprotective pathway, PI3 kinase dependent AKT activation. And in fact, it actually more interesting that if you look at what happens to the cells, palmitate can induce some cell death, and neuregulin, when it's present, usually it's cytoprotective, but when palmitate's there, it actually, neuregulin becomes a cytotoxic growth factor, and this is shown in the bottom left. Palmitate in the squares causes a certain amount of cell death. These are heart cells in culture. And when palmitate is present, even at concentrations that doesn't cause cell death, neuregulin becomes cytotoxic. And this is work done by Tom Miller when he was in my lab back at Boston University. So I don't know if you're following this, but the concept then is, well, if a person is in a state of insulin resistance and or is less active, because they less active have less activity of neuregulin signaling, perhaps they're going to be more susceptible to the adverse effects of anthracycline-based chemotherapy. So coming back to this picture then, this is a system that we think is under the influence of both diet and physical activity, which then opens up a window to say, well, at least from a mechanistic point of view, perhaps we can manipulate an individual's neuregulin signaling if we could manipulate their level of physical activity and or their diet, both of which are recommended, but neither of which is really strongly recommended nor coached in a meaningful way in the clinic. So the usual response to this idea is that cancer patients won't exercise and or aren't interested. So Carrie Geisberg-Lenneman up at Louisville now tried to get at whether that's a true statement or not. She did this survey of cardiac outcomes in oncology patients, and this is data that if you were at the meeting in December you might have seen. I think Carrie presented that. Is that right, Dan? She did a survey using an online tool, and she wanted to get a sense of what people out there in the community are hearing and learning about cardiovascular effects of cancer therapy and what kind of coaching and interest they have in, or what kind of interest they might have in being coached. She got a couple hundred people to respond. Some of them had a cardiac history. There probably was a self-selection group that wanted to participate in the survey. 1/5 of them reported exercise counseling during cancer treatment, and about half of them said they would have liked to hear more about it. Interestingly, 90% of them had not heard about cardio-oncology programs. Now, these weren't selected for people that had treatments that included known cardiotoxic treatments, but about almost 2/3 of them were breast cancer patients. And you can see on the slide the other types of cancer survivors that participated. And kind of reproducing what we saw in the PACE cohort, their self-reported physical activity did decline. This is kind of hard to see, sorry, but if you look at their levels of minimal and mild activity and moderate to strenuous activity on the light gray bars and the medium gray bars, basically before treatment to during treatment, their vigorous physical activity did decline, although there might have been a compensatory increase in mild and mild. I'm sorry, that the mild and minimal activity is the middle bar, and then that did recover after treatment. So consistent with others' observations, the level of activity does go down. Now, many people made on their own dietary modifications. Over half the people reported that they changed their diet somehow during treatment intentionally, and these are some of the ways that they changed their diet. So the most common thing was decreasing their fatty food intake and decreasing their total caloric intake. And you can see some of the other things that people did. So there appears to be ample evidence of decreased physical activity, but also interest in changing things. Now, interestingly, Heidi Silver, who's at Vanderbilt, has been doing clinical work that I want to argue relates to some of the cell work I showed you. So the idea that, and Heidi's a trained nutritionist and physical therapist, PhD scientist, and her read on the literature and about vascular function is that saturated fat isn't just, it's not just that saturated fat is bad, it's actually that a balanced fat diet will help prevent the bad effects of saturated fat. And her view is that changing diets from high fat to low fat, and this is borne out by some of the cardiovascular literature now, is not necessarily the way to cause or enact cardiac protection, but it's actually a shift towards a Mediterranean type diet with mixed fats. So putting in monounsaturated and polyunsaturated fat into your diet in proportion to saturated fat might be the best strategy. And so she's recently published a study where she took a group of obese women and randomized them to a 9 gram per day supplement that included a mix of fats that are shown here, a third of saturated, a third of monounsaturated, and a third of polyunsaturated. And she looked at vascular function in this group of women as well as their weight change and their body composition. And consistent with this hypothesis, their body composition did improve, if you will, with decreased fat and increased lean body mass. Inflammation, markers of inflammation were reduced. And then vascular function improved with an improvement in blood pressure and markers of vascular dysfunction, i.e. TPA activity and PI1 activity, which are inversely related to risk of vascular events. So I want to flip back to this slide I showed you of data from the lab. What I didn't mention is if we put oleate into this cell culture mix with palmitate, which is oleate being a monounsaturated fat versus palmitate, oleate completely rescues this palmitate effect. And so in cells, a balanced fat, if you will, media rescues neuregulin signaling. And in people, a balanced fat diet rescues or improves vascular function. And this has led us to a hypothesis that I want to get some feedback on, that perhaps one of the strategies to improve outcome in anthracycline-based chemotherapy is a dietary intervention like the one Heidi used in those obese women. plus or minus an exercise intervention. And I'm coming at this again, and I showed you some of the evidence for it, but from a basic science view of what regulates this growth factor that is inversely going to relate to anthracycline cardiotoxicity. And so we've, at the moment, are trying to put together this study, we call it PACE-2, where we're going to compare in a 2x2 factorial design exercise intervention, and we're developing an adaptive exercise program recognizing that there are going to be good days and bad days during treatment for patients, and a dietary intervention that's like what Heidi did, and looking at whether they alone or together can prevent some of the early and late cardiac events. And we're working with Bonnie Key at Penn and Carrie Linneman at Louisville to try to make it a feasible study that can be done in a reasonable period of time, and then hoping to pitch this to the NIH for funding or other mechanisms. If people have some suggestions, I would welcome that. And so back to our patient, and then we'll come back to, I hope I get some comments on that study. That woman that I mentioned is now 60. She's 3 years out after her completing her treatment in remission and doing well. Her blood pressure is under control, and she's remained on carvedilol, and she's active with an exercise program. And she's echocardiograms have basically been unchanged over the past 5 years, and her BNP remains in normal limits. So I want to come back now to this picture and see what people think. Jeannie, are you still there?
So Doug, I have a question.
Yeah.
So how are you going to regulate the diet? Just from a, people are so fickle with what they eat, and they tell you one thing, but they're doing something else. And
Sure.
how do you think you might control for that in a clinical setting?
So Heidi is the expert in this field, and she's done dietary interventions for mostly focusing on weight loss during cancer treatment, and has a lot of expertise in this, and actually has really good compliance rates in her studies. Whether that ever translates out into the free world, as they say, is another question, but at least for the study, we have confidence that Heidi can pull it off, or at least help everybody pull it off. One question is whether we use, what Heidi used in the study I showed you the data for is a dietary supplement that was versus a placebo pill that basically had the fat in it. And people were not, instructed too much on what to eat otherwise, but they had this, supplement of fat or no fat. Or sorry, I forget what her placebo had. I guess it had 9 grams. No, I don't think she put 9 grams in the placebo. So this is basically a high-fat supplement versus the usual diet. But I don't know if you have suggestions on that. There are people that have tried to use things like, the Jenny Craig program or a Weight Watchers program, but they actually focus not so much on balancing dietary fat as much as reducing it.
Huh. All right, this is really kind of out there and really a little bit crazy, but
That's what we're all about.
do you think, I don't know kind of patient population, would be recruited for this, but to some extent, almost everybody has a smartphone, and there are apps on the cell phone, like MyFitnessPal, that will break down if you enter in what you are eating, it will spit out what the breakdown of the fat content of what you're eating, and that might be a good place to at least, give people some goals and then have them use something. Again, it depends on patient participation, but at least they could get some feedback about what they were eating to try to be a little bit more compliant with your
That's a great idea. We had currently we'll be using something, maybe Fitbit, which also includes some nutritional stuff on their web. but as a way to track activity.
Right.
And we could incorporate that into the dietary tracking part into it. Heidi's experience is, you have to spend time getting on the phone with people and getting their data, so to speak, of what they've eaten over the course of some period of time, and at least weekly, to track diet and then to coach if that's if it's an interventional group.
Hey, Doug, this is Alan Kono.
Hi, Alan. How are you?
Hey, how are you? Hey, I have a question. I know there's data that suggests that beta blockers in cancer patients, and I think it was lung cancer and possibly breast cancer, the outcome is better in observational studies. Do you think that is a cancer issue, or is it your hypothesis with preventing cardiotoxicity with therapies?
It's a really interesting question. That the beta blockers seem to be associated with a lower rate of relapse and I guess metastatic, whatever expansion, if you will, in big population studies. I think it's Patty Gans's work is the stuff I know off the top of my head. Anybody else chime in if you know other data. I think there's some evidence that the sympathetic nervous system perhaps participates in this sort of inflammasome type, events that drive cancer growth and metastasis. And I think that's, needs to be studied more, but that epi data sort of feeds into that kind of general hand-waving hypothesis. So beyond just cardiac protection. And it's interesting in this trastuzumab group of patients, we found this rise in norepinephrine, which obviously is worrisome if you believe that sympathetic tone is a driver of cancer, and it just kind of feeds into again, maybe we need some big studies looking at beta blockers in those populations, and I know some of those are going on.
Just to follow on a little bit on that comment, so there are a couple of clinical papers showing a benefit for beta blockers in regards to cancer, but the sort of scientific data or the basic science data is in the setting of ovarian cancer with Anil Sood, S-O-O-D, at MD Anderson. He's done a couple of really pretty impressive basic science type reports showing that, a beta blocker reduces the evidence of metastatic disease and it diminishes the sort of stress response that's occurring. So,
yeah. Okay, I didn't know that. Huh.
Yeah, I think it's been in a couple of cancer models actually, so that's what I thought was kind of interesting. But I didn't know if it was. It seems to me it might be cancer and metastases and growth, but also perhaps the therapies, because it seems to me it could actually be a two-pronged prevention.
Well, I think what Doug showed earlier sort of goes along with that general idea that, when people have a higher stress level, however you define that, whether it's by a norepinephrine level or some sort of symptom score, then, attenuating that in whatever way you can minimize that chronic stress is going to make them, better overall, certainly from a cancer point of view, but also from a cardiac point of view.
Yeah, so one of the, I only know what I know, and I can sound like a broken record, but actually one of the wonderful things we've learned is that one of nature's beta blockers, or endogenous beta blockers, are actually neuregulin nerve signaling. They downregulate norepinephrine, and they minimize norepinephrine cytotoxicity. So, and it's through a eNOS-NO dependent mechanism. So again, it kind of feeds into this idea that if we could figure out how to modulate, and that's probably not just neuregulin, that's the one we tend to focus on, or we have focused on. But if we could modulate that, we might do things that don't require an extra drug. And of course, there's problems in giving everybody with breast cancer a beta blocker, and that is there's a large fraction of patients that don't have high blood pressure and are going to have poor tolerance to it. Other comments, thoughts?
I guess you would control for things like statins and whatnot. That might have anti-inflammatory effects, right, in your clinical trial?
Yeah, it's a good question. In the PACE cohort to date, the fraction of patients that were on statins is relatively small. So if we get a similar cohort, well, I'm not sure we'll have enough people to answer the question of how statins interacted. There are ways we can measure the levels of these things that we think are mechanistic, and we're hoping to use that to maybe get at whether there's any evidence for this hypothesis. I advanced to the last slide, which is a piece of art by Laura Pentasuglia, who's was in my lab and now is off in Basel. But we're hoping to get beyond tarot cards for the future patients. Other thoughts?
Yeah, that's a nice nice figure. No, this is great. I think it's really interesting, and it's going to be a challenge to control for diet and exercise. But I think that there is definitely evidence that that will be helpful.
Well, if you say it that way, Dan, it kind of removes the motivation to do the experiment. Because if it's a foregone conclusion, why bother? And that is one of the reviews we got on a grant that we have put in for something similar to this in the past. The statement was something like, everybody knows that it's good for you to exercise. You don't need to study that.
Yeah, but that's not what people do.
Right.
I mean, that's what your survey shows.
Right.
So, I mean, that's not what happens in the real world.
Well, it's especially maybe not what happens in the real world with cancer patients, because they're so focused on their disease and treatments and getting back and forth to the doctors and the exercise, and they feel like crap. So I mean, the exercise part is probably one of the first things to go, I would imagine.
Well, one way we're looking at this is, and the SCOOP survey sort of feeds into this, that this could be a teachable moment. So if you think about your heart patient who smokes and comes in with their heart attack, that is, over and over again, we know that's the time where they're most likely to quit if they're coached right. And the person newly diagnosed with cancer facing a treatment that might affect their heart, we hypothesize might be a similarly teachable moment. So if you knew, for example, that you could change your behavior in a way that might, modify your, late effects of treatment, would you be more likely to modify your behavior?
I would.
Yeah, I think that's what we're hoping, but without the evidence, it's kind of hard to teach.
But I think, you're obviously aware of Lee Jones' data. He did a really nice presentation at the annual meeting. It was actually quite excellent. But, I mean, he was still trying to prove that point that exercise is beneficial, and he did it in the context of pre-op evaluation and whatever. So I think that it's not a foregone conclusion that it's beneficial, and it's definitely not what people recommend in general. I mean, that's what your survey shows. So
yeah, and I love Lee's data. One of the issues, the way Lee does things, is though it's hard to translate in a pragmatic way into the community, because his interventions are very exercise physiology oriented in the lab. So what Heidi Silver is proposing is that we actually develop a adaptive strategy to give people a range of activities, including sitting on the couch with an exercise TheraBand, moving their arms and legs for 20 minutes when they're feeling crappy. And that by doing that and giving people an option, not just a binary, today's a good day, I'm going to exercise, today's a bad day, I'm not, but giving them something to do every day, we could break that and come up with something that would be practical.
Hello, Doug. Can you hear me?
Yep, I can.
This is
Actually, Eric, I can't. You're breaking up for me. I don't know if others can hear you.
I'm in the mountains, so it's hard to hear me, I think.
That's better.
Can we just call them class 2 here? The structure is be a B.
You broke up and I didn't get the question.
But can we enroll them in cardiac rehab? And call them a class 2 congestive heart failure B?
During treatment, you mean, or at the end?
Your guidelines.
Yeah, again, you broke up on that one. But I think what you're asking is, can you use the guidelines to rationalize putting people in cardiac rehab? I think the answer is yes. Will anybody pay for that? The answer is not to my knowledge. So it's kind of be out of pocket. But it's a good point.
Congestive heart failure is now covered under Medicare cardiac rehab, and insurers.
Oh, I didn't. Oh, I heard that was coming. I didn't hear it came. Is that right?
Now, so we call them class 2 and congestive heart failure B because they have structural heart disease, although
Sure.
it's microscopic.
Sure. I think that's a good point. Have you tried that?
I think currently, hi, this is Alan. I think currently you have to have an ejection fraction less than, it's for systolic dysfunction, not mild LV dysfunction or heart failure with normal EF.
It's set into the guidelines congestive heart failure 2, 3, or 4.
Yeah, you're breaking up. We're actually at Dartmouth's initiating our rehab program for heart failure patients, and there is a webinar that one goes to, but right now it's really designed for, and the criteria are for systolic dysfunction, unfortunately.
Well, and I think the other part that is important is, I think most people would not debate that cardiac rehab is beneficial after, say, bypass surgery or stent or whatever. And actually there's plenty of studies that show that it is a beneficial event. But the actual people actually doing it is, it's under 10%. So I think that we clearly have an issue of how you get things into practice. And so I don't think it's a foregone conclusion that exercise is going to be helpful in cancer, during cancer therapy, but I definitely feel that if we could change that practice, it would probably be really an achievement.
Well, I guess we're coming to the end of the hour. I really appreciate everybody listening and giving the feedback and good conversation. But if people have other ideas on how we might improve this idea, I'd appreciate it. Also, if people have any data about or access to data about things like MDR substrates and their interaction with anthracyclines, I'd love to learn that.
Great. Thank you so much, Doug.
Thank you.
Thank you very much, Doug.
I can't hear you, Eric, but I think you said something like thank you, but you're welcome. I enjoyed it, and I look forward to listening in next month.